Here at the United Nations, world leaders met in 2000 and committed to eradicate extreme poverty and hunger by 2015. As part of those commitments, known as the Millennium Development Goals, they promised to reduce by 75% the number of mothers dying in childbirth. 13 years later, we are here in New York to review progress towards this target and to look for solutions. Join me for the big debate as we ask, why are women still dying? Hello and welcome to the big debate. I'm Sigim Gabadeli. Each year, over 250,000 women and over 3 million babies die from largely preventable causes related to pregnancy and childbirth. And the situation is worst in poor countries, where mothers are 15 times more likely to die than in richer countries. But is it just a question of investing more resources, or do culture and tradition also lead to maternal death? Well, with me to discuss this are Catherine Hara, the Minister of Health in Malawi, Anisul Islam Mahmood, a Member of Parliament in Bangladesh and part of the ruling party's alliance, Christian Bach is Development Minister of Denmark, Geeta Sen is Professor in Bangalore, India, and here in the United States at the Harvard School of Public Health. And Babatunde Osotimehin is Executive Director of the United Nations Population Fund, or the UNFPA. And in our audience, we have doctors, health experts, activists, government ministers, and other folk with a passion for maternal health. Welcome to you all. And you can also make your voice heard in the debate. Send us your comments by SMS, you can tweet us, or post on our Facebook page. Before we ask, why are women dying? Take a look at a film called Welcome to the World. Some viewers may find this film disturbing.
Every second of every day, somewhere in the world, a woman is being encouraged to push. The result of all that pushing is that every year, 130 million babies are born, and 130 million mothers experience very special feelings of joy and love. The opportunities available to these young lives will depend very much on where they are born. Fortunately for these twins, they've been born in California. Americans have a life expectancy of 78 years. Welcome to the world, baby Rachel. You are a citizen of Sierra Leone, and you have a life expectancy of 49 years. Luckily, your mother survived having you. 1 in every 8 women in this country die in childbirth.
She ruptured the uterus, most likely. Huh? You can feel the fetal parts underneath her skin, abdominal layer, right? So we'll have to operate her urgently, but we have to stabilize her first, right? I have now been working 25 years in Africa. I've seen this immense suffering of women, and nobody seems to be doing much about it. It's very difficult to do because you need trained obstetricians to do this kind of work. It's very strenuous. We want 3 units of blood at least. Right? They can get it from other donors. Right? This woman who just come in with a uterus rupture, she has 2 days in labor. I do not know where she's coming from. I think she's coming from a very far off place. Had she known that after 6 or 7 hours, if she couldn't deliver, she should have come to the hospital. Perhaps her life would not be in danger. They gave some herbs, right? It looks like herbs.
In the UTI, she vomited lots and lots of native herbs. even before we started the operation.
Mr. Suma, I want to make a team decision now. We are going to operate her now. Is that all right with you?
Yes.
You think you're okay, huh? At that end, you're sure? You do understand that we could have her dead on the table, right? She could die, right? Yeah. Okay, let's go. Hold it up. Here's the baby. The diagnosis is correct.
The baby was already macerated. It might have died days before she arrived here.
Here you are. I'm sorry about this. God's sake, no. I want to finish this off very quickly. She has got to survive this. This is all, nothing else. We only want her to survive, huh? I think we are going to cut the tubes and get the hell out of here. Do you understand? Thank you. She'll have a stormy recovery, as I say. It'll be very stormy. Huh? This patient has only about a 50% chance of surviving. Huh? We do what we can. Yeah.
We shed tears last night. The doctor did all his best, until later on at night she passed away.
Phew. Catherine Hara, Minister of Health in Malawi. It's an emotional film.
Yes, it is.
In Malawi, for every 100,000 births, almost 500 women die. We have made progress, but we're failing that 500, aren't we?
Yes, we are.
Why?
What I think for Malawi, the critical issue has been the age of the mother. Half of the women that are dying, the 500 that you're talking about, are actually younger than 19. And it is because they are not economically empowered, because they have not spent a lot of time in school, they end up getting married early. In the process, they will die giving birth.
That's almost saying that, that's the girls, we're almost passing the buck. What about government resources? What are you doing to ensure that when they do go to a clinic, they will have a qualified health official looking after them?
Well, in terms of government interventions, we've actually intensified our campaign in encouraging the women to come and deliver at the health facilities. But some of them, the health facilities, are 20, 30 kilometers away from them. Now, by the time they get to the health facility, some of them are already in serious complications because of access. And because of the poverty that I talked about, sometimes they don't even have the money to hire a simple vehicle to take them to the health facility.
Anisul Mahmood from Bangladesh, you faced a similar problem to what Catherine is talking about, young girls falling pregnant. In fact, UNICEF says that 50% of girls in Bangladesh are married by age 15.
It is true that some girls do get married below 18. In fact, in our country, the law is no girl can get married below 18. And if it is done, then the parents are liable for criminal prosecution. And one thing I can say today that in Bangladesh, in 2000, we had 322 per 100,000 the mortalities. And today, a rate of 196, that means a reduction of about 40%. And what I feel is that this type of death, not only is the age, it is also the nutrition. It is getting the right kind of treatment. And in fact, we have grassroots workers going out to the families and making them understand what type of food they should take, what type of precautions.
You can do all of that, right, for the pregnant women. But we need to stop young girls from falling pregnant in the first place. We know that young women are 4 times more likely to die during childbirth. So what are you doing to prevent the situation? As
I told you, we have made it a criminal offense.
How many people have been arrested?
There has been arrested, not only arrested, sometimes there are preventive moves. Because the moment a social worker, they come to know, they inform the police, and then the police intervenes.
Let's bring you, Christian Wach, into this conversation. In Denmark, I think the statistic is 12 deaths per 100,000 births. You put that next to the stats in Bangladesh. It's 240, if I'm not mistaken, out of 100,000. And in Malawi, it's about 460. 196 now. 196, is it 460?
460 in
So
Malawi
460 per 100,000. That's huge, right? You're a country that gives development aid. Are we forever going to have the sense that the lives of women in Africa are less worthwhile, or in the developing world, are less worthwhile than the lives of women in the developed world?
Each human being is equal, and these mothers can be saved, and they can be saved by simple means, some of them. And it's core and center of Danish development policy to support women to decide how many kids they want, when they want them, with whom, and also to have them in safe conditions.
But it's not just about resources and money, right? It's about the attitudes in the society that will help us change this.
No, it is. It's about information as well. I've been at health clinics in Kenya, where they couldn't get the women into the clinic because the husband didn't allow them to go to. And of course there are cultural barriers, and then you need to go out, build awareness, and tell the husbands that it's crucial for them and their families that these women can give birth safely at a health clinic.
Geeta Sen, as public health experts and as activists as well, aren't you sometimes a little bit unrealistic? You know, it is a resources issue, and there are cultural sensitivities that we have to be cognizant of.
What cultural sensitivity says that it's okay for something like that to happen? If there is a culture that says that that's okay, then I think we need to repudiate that culture. That's not acceptable. So what people don't understand when they keep talking about culture is that it keeps cascading. We get the girl married, but we don't send her to her husband's house immediately. So she's married at 14, but we send her, a couple of years later. Well, she's still 16 when you send her. So, it's these kinds of things. People sort of keep trying to put little barriers and say, we're not doing anything too terrible here, are we? But when you add it all up, it adds up to the same thing. Contraception is something even for married women and men, after they've proven that they can bear children. The girl has proven that she can bear a child. Well, if she's 16, she shouldn't be doing that. She needs contraception right away. If that's a cultural barrier, that needs to change.
All right, Babatunde, with the UNFPA, one of the things that you've done is really to put at the center of the work that you do the human rights of women and girls. But how much can you really do from New York? What changes can you really make in the lives of the women that we're watching on that video?
Well, UNFPA has a small operation in New York, but we're in 150 countries, working with governments, civil society, women's organizations, youth organizations. And we help governments and communities to mobilize themselves to prevent this sort of thing. So we're not sitting here in New York. And I believe one thing that you haven't said, which I must say, this is about the value we place on women. We have to, it's about the value we place on women. We have to have gender equality. We have to have women valued just like men. And they have to have their space and their rights and be able to exercise those rights.
After the break, we're going to hear from someone who gives refuge to young women and girls who find themselves pregnant and helpless. We also ask whether access to contraception is a key part of the solution to maternal mortality. You're watching The Big Debate. And welcome back to The Big Debate. Now, every day, 800 women die as a result of pregnancy or childbirth, and many of them are young girls. Nyaradzai Gumbo-Nzamfda is the General Secretary of the YWCA, that's the Young Women's Christian Association, which gives refuge to some of these young women. Let's talk a little bit about the kinds of choices that these young girls have.
I think first we need to be bold, audacious, and talk about what we are talking about here. We are not talking about marriage. Marriage is supposed to be valued, respectful. We are talking about sexual exploitation of our girls. We are talking about abuse. We are talking about trafficking. We are giving dignity to an unacceptable practice by calling it marriage. We are giving dignity to my little daughter by saying she's a bride when she's a little girl who just needs to be in school. We need to reshape the narrative, to name what it is. Secondly, the issue of resources. I lead the World YWCA, very community-based, struggling every day to give these girls a little bit of dignity. I challenge the leadership of this world. Africa is not poor. Africa is very rich. We can't accept the narrative of Africa and poverty. We have to put the resources of Africa to invest in the daughters and sons of Africa, for them to have the dignity, the respect, and to end child marriage. We can invest in maternal health. We just need to buy one helicopter less. We need to reduce military expenditure, because these are political choices that our governments are making.
All right. Are we sugarcoating what this is, as Nyaradzai is saying? She's saying it's sexual exploitation. Let's call it what it is, and only then are we going to be able to deal with it. Catherine?
Looking at it at some girl child who has only enough money to go and finish primary school. She's finishing primary school when she's 12 years old. After that, the parents cannot afford for her to go for her secondary education. So indeed, it is exploitation because there's somebody who will come and marry this very young girl.
For me, I totally agree with Nyaradzai. I used to be a Minister of Health. When I look at the proportion of the budget of Nigeria that we spent on health, it was pitiful. We need to get our ministers of finance in this room. Let them understand that the future of the developing world of Africa depends on the young people. They need education, they need health. And any country in Africa that is not spending 40, 50% of its income on the education and the health of its people is not going anywhere.
I need to speak to the Minister of Health in Nigeria. In Nigeria, you're not exactly a poor country. Let's be real. Yet, if you look at your maternal mortality, it's actually gotten worse. What, 600 per 100,000? You are worse than a country poorer than yourselves, that is Malawi.
Maternal mortality rate is 350, still high, but it's 350 per 100,000.
That's still high.
It's still high, but it's not higher than Malawi. But even if it's one, it's still high. No single woman should die just because she got pregnant. I think what we just have to assess is that all of us are guilty. Even the women are guilty. I've just been minister for 3 years, but I was a medical director some years back. And what intrigued me is that a woman comes, just like what they showed us earlier on, ruptured uterus, and you think you need blood. Before you know it, the man has disappeared, and you're asking the woman, where's your husband? I say, never came here. So I think those who have said that, who have really intimidated our women to an extent that they can't even speak for themselves, are right. The women cannot speak for themselves. For me, the greatest thing we need is not necessarily healthcare services, but education, education, education. That is the real empowerment of women.
So a big part of this then is dealing with those patriarchal attitudes that you're talking about. Who's going to educate that husband who ran away and intimidated his wife?
No. When you educate the girl child, she's going to be empowered. She can say no. She will have a voice.
Okay. You spend a lot of money as a country helping in areas such as this one. Do you ever find it difficult to convince your taxpayers to give money for maternal mortality?
No, because we are a country that recognizes that gender equality is at the core and at the value and what can you say, the reason why we're a prosperous country. Because I was raised by a mother who fought for two things. She said economic empowerment of women, and the second thing was that the woman should have the right to decide over her own body, how many children she's going to have, when she's going to have it, and the access to safe abortion. And that brought me up as to become a feminist. And I'm a feminist. And I think that will change the world.
But in some of the countries that you are giving money to, that is not the attitude. So should you then not be putting conditions on your aid?
Well, we are investing in the future of countries by investing in the women of the countries, by the access to contraceptives. That is one important issue, because there are 100 million women in the world that don't have the kind of access to contraceptives as they will. We invest in the UNFPA and in organizations working to talk about sex, because you need to talk about sex to understand what kind of rights every woman should have, because a girl of age of 15 should be in school and should not be the mother of a child and be married instead.
All right. Let's talk contraceptives then. And it's all in Bangladesh. Can a young girl have free and easy access to contraception?
Not unmarried girls. Not unmarried girls. It is the married girls, they have access, though we are a Muslim country.
So you're saying that young girls who are unmarried cannot have access to contraceptives?
They don't have access to contraceptives. That is because there are conflicting ideas. The one is the moment you allow them to have contraceptives, okay, when they are not married, then it takes that the society is more or less condoning on it. At the moment, we don't have this problem of unwanted pregnancies who are not married. There are. I'm not saying that it is zero. So we don't want to get into that problem by condoning it at this point of time. The most important thing is what they have said is the economic empowerment of women, the education. You educate them, you give them economic empowerment.
Let me hear what Gita-san thinks about this, the access to contraceptives. I mean, are we saying go ahead and have sex by handing out condoms and the pill?
Of course not. People come to contraceptives because they've already decided they're going to have sex. You don't have the contraceptives and then decide, oh, now I've got contraceptives, let me go and have sex. So, I think by not making contraception available, all that we do is make it unavailable to those people who are actually going to have sex one way or the other. A friend from Bangladesh is quite right that in South Asia, a lot of sex happens within marriage, but increasingly there's a lot that doesn't. The world is changing even in South Asia. We're urbanizing at a very rapid rate. Age at marriage is going up dramatically. My grandmother was married at the age of 9. My mother at the age of 14. And I was married at the age of 23, but I had my first child at 36, my one and only child. My daughter is 27, and she says, marriage, Ma? Who knows? Who wants that? Now, am I going to tell my 27-year-old daughter, excuse me, you're not married? I'll teach you about contraception after you get married. I mean, she's probably going to say, oh, come on, Ma, I know all about it anyway. Get lost. So we need to get real in terms of the world in which we're living right now, and the world in which we expect our young people to live and be themselves, because this is the world.
All right. When we return, we ask whether the money and the political will is there to save women's lives. You're watching The Big Debate. And welcome back to the big debate on maternal health here in New York. So, let's talk now about political will, let's talk about money, let's talk resources. And we have with us Samir, you are with ActionAid, if you could stand up for me. The money's there. I mean, we were told a bit earlier, Africa's not poor, right? There's lots of money coming from aid, lots of money coming from development. We're resource rich. Why are we not spending it on such an important issue?
I think that's right. I mean, I think we need to connect the dots here. You know, where is the money in Nigeria? It's in oil. Where is the money in Congo? It's in diamonds and other resources. Who is taking that oil? It's British companies, it's European companies, it's Norwegian companies. And are they even... I think the minimum they can do is actually follow the law and pay their tax. But what is happening? Every year, $300 billion is lost to a combination of tax havens and tax incentives, tax transfer pricing schemes and so on. And the northern governments, for all the big talk, way back in 2009, we were told in the G20 that the era of tax havens is coming to an end. Well, we're 4 years on, we haven't seen the end of tax haven.
Would the money be spent on maternal health? Let's say we get it all, right? The money that's there now, who's accountable for how that's spent?
Absolutely. So if we're talking about maternal health, the real, everyone knows, and it's been brought up, the issues are access to emergency obstetric care, the issues are access to family planning, contraception, and so on. And the issues are things like nutrition, longer-term stability, and so on. This is a question of political will internally. But it's hard for me to turn to a country like Malawi being one, or even Nigeria, even a rich country like Nigeria, and say that, look, the tax to GDP ratio is so poor, and security issues are real. In Nigeria, of course, the security issues are very real. So I can't say, can you take some resources away from this and put it in this? Resources need to be generated more. And if you have a tax to GDP ratio that's so low, it means that companies are stealing from you. So let's ask them to stop stealing. Then let's talk about where to invest that money, and invest the money in women, invest the money in rural women, women farmers, invest the money in nutrition, and invest the money in maternal health.
All right. Let's talk about this money that Nigeria supposedly has. Well, Governor Mimiko of Ondo State in Nigeria, we've been talking now about resources, how much money Nigeria has. And I understand that in your state in Nigeria, you're spending quite a lot of money on maternal mortality and dealing with this problem. If you could stand and just let us know what you were doing.
Thank you. The issue of maternal mortality that has been raised is so fundamental, not just a moral issue, it's also an economic issue. Women are responsible for more than 80% of the food that we eat in Africa. Even the services that women provide at home is about 30% of GDP in Africa. So it's one, moral is also economic. Number two, political will is very critical. I am the governor of a state, a population of 4 million. We are about twice the size of Jamaica, 3 times the size of Trinidad and Tobago population. When I came aboard, and I told my folks, we must track every pregnant woman from conception to delivery. Let's remove them from statistics. To our leaders, pregnant women are just statistics. Let's give them flesh and blood. And we put in place tracking mechanism using cell phone. All registered women were given cell phone. They were assigned to health paramedics who visited them at home. We gave them access, transportation. We used 4x4 vehicles. Yeah. We used tricycles. We used motorcycles. So the issue of not being able to access health does not arise. And we said that access must be complete universal. We must break down financial barrier to access, because it is so fundamental. Don't talk about money. It's about organizing our health services, deploying resources efficiently. We have been able to reduce the care of a pregnant woman from conception to delivery, either vaginal delivery or cesarean section, blood transfusion, everything together, $30.
Wow.
By the time I give, the medical director of my hospitals, if I give you $300, I'm expecting 10 live babies. And we have done that consistently.
And 10 live women.
And 10 live women. And 10 live women.
And 10 live women. Thank you. Thank you. Thank you.
Federal minister in Nigeria, it's possible in one state. Why can't we do it across the entire country?
Well, that's why he's the governor. Nigeria is a federal state. And he just told you the population, that's one of the smaller states in Nigeria. There are parts of the country where we don't have the level of education as we have in Ondo State. It is the reality. And that is why sometimes I don't really like to talk about national averages.
Yeah.
Because even as I'm saying Nigeria, 350 per 100,000. Yes, there are states in Nigeria that are less than 120 per 100,000, like his own state now. But there are also states that are still posting as much as 800. That is the truth. But we're talking about national averages, and the state is helping us to drive down that.
Catherine? Catherine of Malawi, tell us a bit about there. I mean, it's possible in Nigeria, it's possible in one state. It's something that they're seeing in different states. They're talking about political will. Is that something you can take on board?
10 years ago, we were at 1,200 per 100,000. We've gone down to 460. Most of it has been because of the initiative that the President, Dr. Joyce Banda, has put. And then as much as we might say culture is not a barrier, but in my country, we take that, it does contribute to maternal death. For example, a woman would not go, even if she's married at the right age, she wouldn't go to the hospital to do a delivery if the mother-in-law has not said yes. The president has actually championed a traditional leader who will, in his own right in the village, say, these are the cultural practices which I think are not right for my people. And that is make it better because it is them making that decision.
You're nodding because leadership is key here, right, Christian?
Well, leadership is key, breaking taboos is key, fighting resistance is key. There are 200 million women who don't have access to modern contraception. And just by giving them that, we could cut maternal mortality by 1/3. And that is also due to resistance. It's all the way from popes to priests to conservative politicians. And we need to confront it, and we need to do something about it.
When we return, we're going to get the final word from our panel and our audience. You're watching The Big Debate. And welcome back to The Big Debate on maternal mortality. Why are women dying and what should be done about it? What do you think?
My name's Afua Minta. I'm an OBGYN practicing here in New York City. I'm the Assistant Residency Program Director at Beth Israel Medical Center, and I actually brought 3 of my young residents who are interested in global health and maternal issues. So my question to the panel is, what can we do from here, from the developed world, especially with young trainees that we work with? What can we do to help address the global issues?
The governor said that beyond, we need to rescue women that are not educated, that are unfortunately pregnant when they're not prepared to do that. Now, these women don't have a say, are not empowered economically for them to make choices of hiring even a taxi or hiring a bus to take them to the next health facility where they can actually seek help. We need to economically empower these women so they can make decisions when it's right for them to be able to access healthcare delivery service.
The main bodies of the UN, when they talk about the MDGs and maternal mortality, the word sex does not come up. The word contraceptive does not come up. There are a group of Muslim countries, in fact, most of them, and a group of strictly Catholic countries that would faint off their chairs if it were mentioned. And I feel that UNFPA, we're talking to each other, and I'd like you to comment on that.
The private sector has managed to reach the last mile. You can probably drive to the very last mile at the very farthest corner of the earth and find some product that some private sector company has made. Why are we not harnessing that power? Where is the private sector in this conversation? Where are the ministries of education? Where are the ministries of finance? I have so much enjoyed UNGA Week, but I have really missed the other sectors who have a voice here and who have the power to make things happen.
I really feel we really are not creating the space for the young people to just be there to speak for themselves. We are talking about them, but they are here. What can be done for us to create space for the young people to talk their own stories? Because we trust them to vote for leaders, at age 18, but we don't trust them to talk about themselves, about their health.
My name is Dr. Lawalo Inei. I'm a consultant OBGYN, and I happen to be the Chief Medical Director of the Mother and Child Hospitals in Ondo State, as well as the chairperson of the Confidential Inquiry to Maternal Deaths in Ondo State. We discovered that once you provide quality health services, once that is provided and is maintained, what happens is that women come to you without the issue of delays in intervening. What actually makes you spend money on maternal health care are the complications following delays in management, the ruptured uteruses, the eclamptics, the excessive bleeding. Once there's a system in place where quality of care is made a priority, women will make themselves available. Once they don't have to worry about paying at the point of service, they'll make themselves available. And what you find out is that less women will have complications, and then you get an improvement in your healthcare financing. Thank you very much.
And I'm wondering how, given that MDG 5 is one of the most off-track MDGs, we can ensure that in the post-2015 framework, maternal health care is prioritized and states are held accountable when they don't prioritize it.
We have this saying that like father, like son. And we are talking about the girl children getting pregnant, but we're not talking about the young guys. Because most of these young girls they get impregnated by the young men. And they don't marry them. They just meet them and they impregnate them. So is it that the girls are interested or the boys force them to impregnate them? And is there a situation that created the girls being prone to these young men? Those mothers who died from childbirth, who is going to take care of their children? These children will become, they'll be on their own. And these children might wind up becoming pregnant at teenage ages. So the situation is kind of compounded. We have to really sit down and digest and see what we can do to help these children. It's not only the girls, but the boys also.
My name is Zain Dango. I'm the Special Advisor to the Minister of Social Development in South Africa. I think the point that's being made, and I think South Africa is a very good case study, is that we've got similar policies to what Denmark has, but the outcomes are not the same. And that brings the issue of rights into the equation. We've got all the formal rights, but the fact that 50% of our maternal mortality is driven by HIV and AIDS and complications linked to HIV and AIDS, and if one looks at the epidemic and the fact that young women are particularly vulnerable, the key driver is a lack of rights and the refusal of society to accept that women own their own bodies and patriarchy. And I think what we need to do is put the issue of rights right into the equation, because for us it's the attitude that hasn't changed. And you link that into health systems deficits, then we're not going to get the maternal mortality down.
Hello, my name is Ajwa Duker, and I'm a family practice physician here in New York, and I also studied family planning and public health. And my question is in regards to large-scale efforts to increase numbers of midwives and home birth attendants, and that would be a significant help in reducing maternal mortality. Another concern of mine is in regards to improving access of women and young adolescents to emergency contraception and also access to safe abortions, because countless numbers of women are dying due to unsafe abortions. So those are my concerns.
After the break, the final word from our panel. And welcome back to the big debate. Let's hear a last word from our panel here at the United Nations in New York. Catherine Hara, your final word.
I think if we're to address this issue, it has to be a holistic approach, because it has got a lot of faces to it. It's got a health face, it's got an education face, it's got an economic face, it's got a cultural face. So if we are to address the maternal mortality, indeed, apart from the health, we need to address it in a holistic approach. As government of Malawi, in terms of resource, sometimes we talk of resource and we think of a dollar only. But I think our human resource, as well as our commitment, is a very critical and important resource. And I would like to say that as a country, we've actually also tailor-made some of the solutions to the problems. For example, the president did initiate a program whereby we're building maternity waiting homes. The women will come maybe a month or even 2 weeks earlier and be accommodated within the hospital premises so that when labor starts, they are closer. And somebody talked about private sector. These waiting homes, the president, through her initiative, she's actually coerced organizations and companies to actually put their brand name on these waiting homes. But the doctors that did say that are available, we definitely still need them if they are available to come to Malawi.
We'll pass some numbers on. And as briefly as possible, Anisul Mahmoud, your final word.
Thank you. First of all, it is very easy to say what is the ideal. Ideal is zero. And it is very easy to talk about change. And we have seen how political slogan of change, even in a country like the United States, has not done the miracle. And we have seen in Ireland where a lady lost her life because abortion is not allowed. And abortion is still a debatable question in a country like the United States. So when we talk about change, we have to be realistic. What is needed is a change in the political will, change in taking actions. For example, in Bangladesh, we are providing not to all, to the most vulnerable group, a motherhood stipend. That is, when a vulnerable girl, she is pregnant, she is given a certain amount of money so that she has access to better food and better health condition. We gave 6 months holiday for anyone who is pregnant and who is in a job. 6 months holiday. So these are the things which we're doing. And then the most important thing that we feel are two things, which is education. For education, what we have made is, it is free education for girl students up to secondary level, and books are given free. We also are making resources available to the woman. Any resources that is going from government, the emphasis is that should be directed towards the woman of the household to receive it. It is no use saying a girl who is dependent on her marriage, okay, to say that I'm going to defy. It is not going to happen. I can say it here to the gallery, but that is not going to happen. We have to give them the economic resources available through government policies, and we have to give them education. If we can do that, then the change will come. But it will take time to change the attitude of the society. Thank you.
Question.
Well, the question was, what can we do in the rich countries? And first of all, I guess we can live up to our promises.
Yes.
You know, there's so many countries who want to become a member of G7 and G8 and G20 and all of it. So Denmark, we have established a new club. It's called G0.7. And it's a club of countries who give more than 0.7%. And it's still a very exclusive club. There are only 5 members, so please please join. And then we can make sure that we allocate a larger share of that funding to sexual and reproductive health and rights. And then we must make sure, there was another question, we must make sure that sexual and reproductive health and rights becomes part of our future post-2015 development agenda. It has to be there.
All right, let's just clarify your club because I want people to join it, right? So it's for countries that give more than 0.7% of their GDP
in development aid.
Into development
and
aid.
if you join, you get a badge as well.
I want a badge. Geeta Sen, your final word.
I wish I could join that club, Minister. I think it's about really, at the end of the day, it's about two things. It is about the recognition that the rights of girls and the rights of women are at the heart of this problem. You've got to have a much more comprehensive approach, which includes comprehensive sexuality education for young people. They need that as part of their education so that they know how to protect, young girls know how to protect themselves, how to make sure that they don't get pregnant, how to make sure that they can actually become empowered. It's not enough to say, go to school and you're empowered. They're not. They've got to learn how to be able to do that. And instead of shrinking and scaring ourselves by thinking somehow, oh, give them contraceptives and they become promiscuous, give them education and they'll all be running around having sex. In fact, all of the evidence says exactly the opposite. Exactly the opposite. So it's about rights, and it's about taking a much more comprehensive approach to it, and it is about political will. It is about those resources, and much as I might agree that one has to, make sure that the resources stolen and gone away are brought back to countries, countries are so rich, and they don't put the money because they don't think it's important. And that's the fundamental difference.
Babatunde, your final word.
Well, it's always nice to be the last. Let me start by saying, I think that political will must be the first and the most important. And I say this with clear evidence. One of the best performing countries in maternal mortality is Sri Lanka. It is not a rich country, but actually would have reached the MDGs 50 years ago if we had invented it. Because there was a political will to make sure that women and girls got services close to their homes. Let me also say, for the 0.7% club, what is important to understand is that many of these countries actually lowered maternal mortality before they became prosperous. Canada did it, and there are many examples. So it is not about money in that sense. It's about the value we place on ourselves and on women and girls. But finally, and I say this, I say it everywhere, and I've proposed it in the next development agenda, we must have a goal for adolescent girls. There are 600 million adolescent girls in the world. 90% of them are in the developing world. Can you imagine a world where every of these adolescents has education, healthcare, skills, decent jobs, be able to make choices in their lives, who they marry, have access to contraception? Can you imagine that world? It's transformative. Thank you.
Well, to contribute to our future shows, don't forget to like our page on Facebook and follow us on Twitter. Now, in 2015, world leaders will celebrate progress towards the Millennium Development Goals, including MDG 5, which promised to reduce maternal mortality by 3/4. But those celebrations will ring hollow for the poorest of women who still face the greatest risk of death when they become mothers. Have our leaders done enough to prioritize women's health? Are we all prepared to invest the money and change our mindsets so that having a baby can be a positive, life-giving experience everywhere in the world? You decide. Thank you for watching The Big Debate. Goodbye.